Presentation. I'm happy to be here to discuss specifically about this topic, extended resection for rectal cancer, which is my main topic, as you just told. So, a few years ago, 5 years ago exactly, there is a consensus which has been reported. And it's interesting because in this consensus, you can find all the procedure, all the indication for both local recurrence and primary locally advanced rectal cancer. But exonerative procedures are based on preoperative treatment in this consensus, according to the author's report. And the literature taking into account the downstaging of this big lesion is really scary. However, since this last 5 years, there is this publication. This is GRECAR4. This is a French group of research regarding rectal cancer. And in this GRECAR4, we assess the induction chemotherapy for big lesion with predictive CRM lower than 1 millimeter. So we have big T3 or T4. All patients, as you can see, received FOLFIRINOX 4 cycles. And then we randomize the patient according to the response. Good responders were patients with a shrinkage of the lesion higher than 75%, which is just amazing after 4 cycles of FOLFIRINOX. And these patients were randomized between immediate surgery or CAP50, which is the standard treatment. And then bad responder were randomized between CAP50 or CAP60. That means we increase the rate of radiotherapy for bad responder. And at the end, the primary objective was to obtain R0 resection higher than 90%. If we have a look on the results, you can see that patients with good response, we have 100% of R0 resection, whereas with bad responders, the R0 rate was between 82 to 87%. It's interesting to see as well the downstaging, not only the complete response. You can see that in patients with good response after FOLFIRINOX followed by CAP50, you have more than 60% of complete or subcomplete response in patients initially with a big lesion. And if you consider patient with good response, the downstaging is higher than 80% in patients with FOLFIRINOX followed by CAP50. And if you have a look on the tumor volume reduction, it's just amazing to see that if you consider the whole population, all patients have more than 80% of size reduction. It's incredible. Then, regarding the surgical management, you know the TME plane. All of you know this TME plane. It has been reported several times, and it's really good report. However, surgical procedure for T4 rectal cancer are completely different, and you have a wide range of procedure that you can perform. You can perform extended TME. That means that you will perform a partial resection of the adjacent organ, less than 50% of this adjacent organ, en bloc with the TME specimen, or pelvic exent. And in pelvic exent, you can perform posterior pelvic exent, total pelvic exent, with or without the levator ani muscle, according to the height of the lesion, with or without sacrectomy, according to the involvement of the sacrum. What about extended TME? There is really few data in the literature. This paper has been reported in 2009, and authors compared patients with T4A and compared patients with R0 or R0 or R1, R2 resection. At the end, they conclude that the MRI is not specific enough to differentiate fibrosis and tumor, and so they recommend to perform the surgery according to the first pre-treatment MRI. We have another paper published by Spanish group in which they compare prostate resection, partial prostatic resection, total prostatic resection, no prostatic resection, according to the CRM between the tumor and the prostate, CRM threatened or CRM infiltrated. And you can see that with patients with partial prostatectomy, that means that we do just a shaving of the posterior wall of the prostate, urethral damage has been reported in more than 35%, and urethral fistula in about 20%, which is very high. But we have to compare it to a total pelvic exenteration, which is the conventional procedure proposed to this patient. However, for this patient, authors never consider the downstaging of the lesion. So we report with the Marsden Hospital, we pulled our data 3 years ago, and it has been published in 2016, and we compared the surgical procedure according to the downstaging. You can see that patients with induction chemotherapy had a better response than patients only with CAP 50, which confirmed the results of GRECA-4. Then you can see that even if it's not significant, there is a huge difference regarding airrun resection between patients which were responders or no responders. Then you can see that in the group with responders, we perform almost 30% of TME. That means that the plane of surgery which were involved initially, because it was only T4 lesion, after induction chemotherapy and chemoradiotherapy, we achieved a safe margin allowing us to perform a TME resection instead of an extended TME surgery. Then you can see as well that we perform a shaving of the prostate, but only in the group of patients who respond to the preoperative treatment, and never for patients without response. It's completely different to the Spanish group. Regarding the local recurrence, there is obviously difference, significant difference between no responders and responders, but in groups of patients who respond, whatever the surgery you perform, you can perform TME, you can perform extended TME or pelvic exent, it doesn't matter. This is the same results. But in the group with no responders group, you have to avoid ETME, because if you perform an extended TME, that means only a partial resection of adjacent organ in patients without good response, the rate of local recurrence increase and the morbidity increase as well. So for these both reasons, morbidity and local recurrence, oncological results, you have to avoid extended TME and you have to perform beyond TME, that means pelvic exent, in patients without response after induction chemotherapy followed by radiochemotherapy. This was our conclusion. That means that if you don't have response, please do not do ETME, but perform an exenteration, pelvic exent. So for the surgical procedures, if we want to discuss about it, we have to take into account pelvic compartment. And according to this pelvic compartment, you will have different strategy of surgery. For central or anterior location, we will be perform TME, if we have a very good response, partial or total pelvic exenteration, with or without levatorani muscle. If you have a posterior location, you can perform a sacrectomy, and we will discuss about it, high or low sacrectomy, or if we want to avoid a high sacrectomy, and if the location of the lesion allows us to do it, we can perform a subcortical dissection of the sacrum. And then for the lateral location, obviously the surgical procedure will depend on the depth of the pelvic sidewall involvement. So the compartments of the pelvis, taking into account this compartment with anatomy and radiological assessment, is the first step of all standardization. We just have to talk about the same things about compartment. I think that we have to differentiate surgery with low risk of R1 resection, and it's mainly anterior or central location, that means with urinary or genital involvement, in which you can perform TME or partial or total pelvic exenteration. You can see that we have to standardize the anterior plane, the posterior plane, lateral plane. In this surgery with urinary or genital involvement, you don't have to perform ligation of vessel. I mean that you have to stay into the vessel. You can remove the urethra, but never ligation of the internal iliac artery or vein. Okay? So the risk of R1 is low and the morbidity is lower than extended surgery outside the vascular plane. One technical point, you know that when you want to do urethra and dorsal vein complex ligation by abdominal approach, very often, even with urologists, you have massive bleeding, about 1 liter. If you perform a perineal approach, you just have to expose the inferior pubic rami, follow them up to the basis of the verge, and then you enter into the pelvis and you just have to do ligation of both the urethra and the dorsal vein complex. In this way, you avoid massive bleeding and you can join the plane you perform before by the abdominal approach. This is a little technical point, but very important because in pelvic exent, one of the issue is the hemorrhage and the bleeding. Then, I just tell you that probably that we have to standardize and to spread the surgery for patients with genital involvement because it's easy to do. But if we push the decision, if we push the consideration of surgery sparing sphincter and urethra, we have some case of patient with only involvement of the prostate. This involvement is too deep to perform just a shaving. And you can see this is the biggest report in the literature, only 20 cases of en bloc resection of prostate and rectum with both anastomosis, urinary and coloanal anastomosis. There are only R0 resection, but 10% of local recurrence with 1/3 of patients with leakage. We have our own practice about it. We perform 10 patients in 2 years. We have no leakage, but unfortunately we have 2 patients with R1 resection. And this picture is the last one we performed 1 week ago in robotic surgery with transanal extraction. And this patient has 2 anastomosis without stoma. When I discussed about it with my colleague from the Marsden, they told me that we are completely crazy, but it works. And this patient is only, the last patient is only 52 years old, I mean. So he's really happy to avoid both stoma. He's still in the hospital, but he will go back home on Monday. So it's, I think we have to think about it. But the main issue is the function, obviously. You can tell me, but what about the function? The function, you can't do it, but you can't do intersphincteric resection or coloanal anastomosis if you don't take into account the function. And you have to follow the patient very closely. That means that within the first year after surgery, we see the patient at 1 month and then every 3 months. And we adapt with dietary rules, with antidiarrheal drug, with mucilage, with retrograde enema, biofeedback, SNS if necessary, etc., etc. You can't lose the patient in this condition. And we obtain more than 80% of good function without loss, I mean. Then for the urinary, because obviously the patient may have incontinence. So our politics is to do an urinary prosthesis at 1 year if we don't have any oncological issue. And before surgery, we perform preoperative re-education with biofeedback. We learn it about our colleague, our urologist colleague, because for all prostatic resection, they perform re-education before surgery, whereas we don't have this consideration for our patient with rectal excision. That means that we can progress. When you work with your colleague, you can progress. And the main requirement is probably the patient selection and information about the close follow-up they will need during the postoperative period. So it was for the anterior and for the central location. What about posterior and lateral location? In this specific case, I strongly suggest that in each country we need some specific center, and all these patients have to have a specific clinical pathway with centralization. So for the posterior location, 3 possibilities. High sacrectomy. We talk about high sacrectomy when we have to remove S1, S2, subcortical dissection, or low sacrectomy when the sacrectomy is lower than S3. So for the high sacrectomy, the first step is in lithotomy position. You have to control the vessel. That means that you have to stitch and to cut the iliac vessel, internal iliac vessel, preserving the superior gluteal artery if you can, in order to do a flap, if you want, with the gluteus. And then you put a metallic pin into the sacrum in order to have a landmark when you put the patient in prone position to do the bone transection. Sometimes you can do this surgery in 1 step. Sometimes you can do in 2 steps, I mean with 2 days. When you have a massive bleeding, sometimes you have a massive bleeding with a lithotomy position. You disconnect everything, you stop it, and 1 day after, you put the patient in prone position for the bone transection. So it's really important to have a very comprehensive and a very competitive anesthesiologist team and intensive care team as well. What about the limit? The limit is clearly defined as S1 involvement. I think that all over the world now there is no more team performing total sacrectomy. Okay, so we perform S1, S2, but never total sacrectomy. I think that even in Sydney, I spent 5 months in Sydney 3 years ago with Michael Solomon, they stopped to do it. Okay. What about the function? I mean, if you have only a sacral resection, are you able to preserve the bladder, for example? The first usually you lose the vascularization, but moreover, you can see in this study that if you cut above S2, S3, in more than 50% of cases, you lose the function of the bladder. So it doesn't make sense to preserve it. So how to avoid the high sacrectomy? So it's like for prostatic involvement. It's for specific patient. That means that if you have a posterior involvement of the sacrum with a central location between sacral foramina, you can perform subcortical dissection. It has been reported a few years ago by the St. Mark's team and Jan Jenkins. And this is a case we performed 1 year ago, and you can see the specimen. You can see the specimen is S2, S3. You can see the cortical. And when we perform a CT scan in postoperative period, you can see that we removed the presacral cortical, and in front of the sacrum, we put the great omentum. So in this patient, we preserve, you can see that we remove the vesical seminal, but we preserve the bladder. That means that we don't perform total pelvic exam for this patient. We perform APR with subcortical dissection. Then, what about low sacrectomy? You can perform low sacrectomy in prone position, but you can perform it as well in lithotomy position. This patient, so it's a 60 years old male with posterior location, you can see that there is a posterior involvement here. This is only fibrosis. That means that our plane of surgery came there, and there we have an involvement of the S4, S5, and in front, anteriorly, we have an involvement of the vesicle seminal. As you know, the sacrum do this. So when you arrive from the abdominal approach, you can cut it. You are in the plane of S3, S4. You just have before to dissect by perineal approach this plane posteriorly in order to do the junction there. So you have before to cut it, like you saw, you have to do the perineal step in order to do the junction like here. This is exactly like this. And then you can see the specimen. So it was, we have the sacrum there and the coccyx came here. We have the vesicle seminal vas, and then anteriorly we leave the prostate and the bladder. For the pelvic side wall dissection for lateral location, first you have to do ligation of the internal iliac artery. If you have to keep the superior gluteal artery. It's better for the patient. This is the first branches of the iliac internal artery. Then when you remove the artery, you find the vein. You can't stitch the vein before stitching the artery. And then you have to be very cautious with the vein, because with the internal iliac vein, you can have massive bleeding. And you have to take into account that in each level of the sacrum, you have a sacral branches, a gluteal branches, and a visceral branches. And if you forget to stitch one of these, you will have a massive bleeding, and it will be very difficult to stitch and to control it. Then, when you have stitched the artery, the vein, you open the space of the lumbosacral trunk and the sciatic nerve. And you can control very easily the nerve at this level. So this is a conventional approach. By abdominal approach, you have to control. Then if you have to remove the ischial spine, you go down the ischial spine, and with a jiggly, you can cut it and open the really deep compartment. You have to cut the obturator internus, and then you achieve the space of the ischial spine. This is a conventional approach, but this is the LC approach described by Jan Jenkins. We just arrived, and he reported this approach 4 years ago in order to improve exposition of the lateral compartment. We performed for this woman. You know, she is 65 years old with the right side pelvic sidewall location. So after dissecting the gluteal, great gluteal, mild gluteal, you expose the piriformis. Then you can cut the piriformis. When you cut the piriformis, you enter in the area of the sciatic nerve. This is the sciatic nerve. By this way, you can have a really safe control of the sciatic nerve. And if you have to shave it, you can shave it if there is tumoral involvement. Then, when you control it, just in front of the nerve here, you can see the bone. The bone is the ischial spine at this level. You can cut the ischial spine. It's really safe because you control everything from here. There is no reason to have massive bleeding at this level. You control the nerve. You cut the spine. You can see it. You can choose. You cut 1, 2, or 3 centimeters, the whole ischial spine. After doing this, you just close it, put the patient on lithotomy position, and do your vascular ligation in order to refine this plane that you performed before. In this way, you can remove in safe condition the ischial spine and unblock with the pelvis organ. You see, we just put a gauze after cutting the ischial spine, and then we will find again this gauze when we will do the abdominal approach. And at the end, this is the specimen of this woman. You can see with the wall, lateral side wall compartment. So what about the take-home message after this talk? First, that we have a wide range of surgical procedures for extended resection in rectal cancer. Then the key point is probably the clinical pathway. It's really important for posterior and lateral location. And at the end, I think that now we have enough data in the literature, and probably that we will have more and more, in order to perform induction chemotherapy and radiochemotherapy in this patient in order to obtain downstaging and then to perform the surgery according to the second MRI and not to the first one. And at the end, I take the opportunity to invite you for our next colorectal masterclass in Bordeaux. So this was in October, 2 weeks ago. The next one will be in March. It's a 1-week masterclass with live surgery every morning, with colon and rectal cancer, IBD, functional disorder, all the week. And on the afternoon, we discuss with all experts coming from all through Europe. Thank you.
Absolutely fantastic. I think it's amazing to see what can be done. I think the important thing for us is to realise that if you've got a centre regionally or nationally, then you've got patients with very complex tumours, and to understand which of those patients can be sent up and treated, even with really quite extraordinarily advanced disease. Any burning questions from the audience? I expect you're probably slightly overwhelmed with all of that. It's pretty complicated. I'm just going to ask, I'm sure Ian might have a question to contribute at some stage, but how do you decide when you're doing a subcortical sacrectomy whether you can do a subcortical or whether you need to do a full thickness sacrectomy? How do you determine?
If first we don't perform S1 resection, this is the highest level, S1, S2. Then the location have to be between sacral foramina. Otherwise, you will, or you can cut, but you cut definitively the sciatic nerve. Yeah. So our recommendation is to perform it when you have cortical involvement between foramen and when you want to avoid high sacrectomy. That means that between S1, S2. And then obviously you can't do a subcortical dissection through 15 centimeters. It's just for 4-5 centimeters. In other words, it will be really difficult, even if now orthopedics have a CT control in order to guide their procedure.
So basically, fairly localized involvement of the sacrum centrally. That's when you would do a subcortical.
High involvement centrally.
Yeah. The other thing is, you're preserving the sacral nerves, so you preserve bladder function. But in order to do a sacrectomy of any type, presumably you do need to control the internal iliac vessels. So I understood that you were able to preserve bladder vascularity, bladder blood supply, at the same time as controlling the bleeding around the sacrum. Is that correct?
Yeah, you can preserve it when you perform a low sacrectomy, lower than S3. If you perform a high sacrectomy, you can't preserve the bladder because you will lose the vascularization. Then you have to know that when you perform a sacrectomy S3, S4, you can lose in 50% of cases the function of the bladder. Yeah. But when you perform a subcortical dissection, you can keep the bladder. Yeah.
But can you keep the blood supply to the bladder?
Yeah. Yeah. If you perform a subcortical dissection, yes. So
but the first we described, blood loss is much less.
This procedure is young, so you can discuss.
As I was saying, so the blood loss, you don't require to tie off the internal iliac vessels to do a subcortical.
No,
dissection.
You have to control it in order, or if you have bleeding, you have to control, but you don't have to do ligation.
Yeah. Okay. Great. Excellent. We've got some questions being generated.
I think that's quite extraordinary surgery. But in terms of reconstructing the pelvic floor afterwards, are you using flaps and things? Because obviously you can be left with big defects. And I sort of understood we're going away from flaps slightly because they hadn't worked so well in the literature, the gracilis flaps and things.
Yeah, we use either VRAM or gluteal flap. Very often, I prefer to use gluteus flap, but it's just a fasciocutaneous flap. I have to be honest, I learned it 3 years ago when I came here. I spent 6 months in London and I came once a week here, and I learned with a plastic surgeon who works with Jan, and he told me, you know, you don't have to be plastics to do it. It's a really strong flap, and it's completely right. I mean, I perform it once a week in Bordeaux, and just when I have to perform a VRAM, I call the plastics. But for the fasciocutaneous gluteal flap, it's really a really strong flap. But you have to do flap, yeah. In otherwise, you will have issue of the cicatrice, of the healing process.
And these are eye gap flaps, the inferior gluteal vessel flaps, and you have two advancement flaps, triangular advancement flaps that are brought to the centre based on the gluteal muscles. That's correct, isn't it? Yeah.
Thank you very much. That was a really interesting talk. I just wondered, you know, whether, because you can predict your R1 resections based on tumour biology and anatomical location, whether you felt there was a role for intraoperative radiotherapy in some of these patients.
Intraoperative radiotherapy.
Yeah.
So we discussed only of locally advanced, I mean T4. I did not discuss about local recurrence, which is another issue. But I told you that I think that for T4, I mean without any pre-irradiation, you know, we have to give chemotherapy in front, because you can assess, it's like a biological marker. I mean, if you have a really good response, that means that just with CAP50, then you know that you will have a shrinkage of the lesion, and you can adapt your surgery according to the downstaging. If you give chemo and you don't have any downstaging, then you have to give radiochemotherapy, but you have to do a surgical procedure according to the first MRI, because otherwise you will increase the morbidity, you will increase the rate of local recurrence. So I think that's, you know, giving chemotherapy as induction treatment, it gives you a lot of information for your surgical procedures and what we will be able to do. But radiotherapy, intraoperative radiotherapy, I think that it's really difficult to, you have to build a team able to do this. We don't do this. I don't know if it's really, you know, useful. I don't think that there is so many teams around the world doing this. We will assess re-irradiation for recurrence for patients who were saved during the primary cancer preoperative radiotherapy, but intraoperative radiation, we don't do it. I don't know. I think that in St. Mark's you don't do it as well. No? No.
No.
No. I think that it's a really small number of centers around the road.
You were saying that for threatened margins, you're now giving induction chemotherapy and assessing response. Good responders can go straight to treatment without radiotherapy. What was the standard of care in France before that change?
So threatened margin, I mean, it's not involved margin. We agree, it's clear. So in France, we will have new, you know, we built trial and trial in order to show something. But I think that with GRECAR4, we have enough information to be able to do this. But after that, you have politics as well. That means that in your MDT, when you have the radiotherapist and you tell, okay, after the chemotherapy, we will give chemo and we'll see. Very often, you have some.
And have you, clearly there'd be some advantage for the patient not having to have radiotherapy. Has it been demonstrated that there are better functional results after?
Yeah, we know that we perform a lot of coloanal or low colorectal anastomosis. We know that patient without radiation has better function after surgery. So it's really important. When we can avoid it, avoid it.
I mean, you're operating on people who've got 20, 30 years of life left, and having anterior resection syndrome or very dysfunctional bowel is debilitating. It can be really a big problem. So just to reiterate that, thank you. Any other questions?
Just a comment. I just wanted to say it's great to see you, Quentin. It's always great to hear you speak. I think you're a wonderful speaker. It's great to see you pushing the boundaries in France, because I don't think until you embraced a lot of this that the French were necessarily willing to sort of push the boundaries. So congratulations.
Thank you.
Thank you. Thank you very much indeed.